Welcome everyone to the YES Online Research Webinar Series. I am Sally Shaban, a neurologist from Egypt, and I will be the moderator for today's session. Explore how seizure can cause brain damage from both basic science and clinical research. Before we go through the session, there's a quick note that our final session on neuromodulation and DBS protocols has been rescheduled for June 18th. If you want to keep and stay updated, just scan this QR code and you will receive reminders and notifications. By the way, these webinar sessions are proudly organized by the Research Task Force of the Young Epilepsy YES under the support of the International League Against. We invite you all to join the YES community. It's a dynamic global networking that offers exciting opportunities for international collaborations, research projects, and continuing educational activities on both epilepsy care and research. If you want to explore and learn more about YES, you can visit YES YouTube channel and you will find many webinars and courses dating back to 2019. And if you are younger than 40 years old and would like to get involved in our YES activities, simply scan this QR code and complete the registration form. Then you will be directed to our group. And if you are interested to meet us in person and meeting the team, we will have YES sessions and networking event at the International Epilepsy Congress on the 1st of September in Lisbon. Plus, currently there is a call for booster 2 leaders. And if you would like to apply, just scan this QR code. And sorry, I think scanning all these QR code is not possible now. But don't worry, I will post all these links in the chat, okay? Now, let's introduce our two amazing speakers. It's our pleasure to have Dr. Marco Di Cortes. He is the head of preclinical neuroscience labs at Carlo Besta Institute in Milano, Italy. Dr. Marco is a leading expert in experimental neurophysiology and active member of multiple ILE task forces. Dr. Marco also a co-founder of Epilepsy Summer Schools and a director of many educational courses to bridge the gap between basic science and clinical research. And he will address today's topic from the new science perspective. And we are also honored to have Dr. Marian Galovic. He is the head of epileptology department at Zurich University Hospital in Switzerland. And he is an expert in epilepsy neuroimaging and brain volumetric research. And to be noted, Dr. Marianne was the first chair for the YES community who organized the very first YES webinars, leading the way to all younger researchers worldwide. So a huge thank you to both speakers for their generous support and for being with us today. And without further ado, let's start by the new science perspective. Dr. Marco, the floor is yours. I will stop share screen now.
Thank you very much. It's always a pleasure to participate to these YES events. It's very exciting, very interesting. Topics are also very challenging. And the topic of today is particularly challenging because I think we do not have an answer. And probably the answer depends on the type of epilepsy and so on. And this is a very old topic, so it has been discussed several times. But I don't think there is still a clear answer. And I'm happy to share the floor with Maria Galovic, who is representing will be presenting a lot of work done in the clinical field, clinical epilepsy field on the topic. So I will try to set the general framework, which is the following. So when epilepsy develops, so during the process of epileptogenesis, we have a cause for that. First, brain insult can be any type of insult, can be a tumor, can be a trauma, can be a status epilepticus, can be a genetic defect. This will generate some brain damage, okay? If the insult is ongoing and is keeping with time, for example, in autoimmune diseases, there is a first insult, and then the changes promoted by the autoimmune encephalitis, they modify the brain. The damage can be ongoing, so it's not only one shot, one alteration of the brain, but the brain is keeping keep changing in a pathological way. And this can generate at some point an epileptic network. And that's why we call this epilepsy. Okay? Epilepsy is defined by the presence of seizures, but these seizures can increase the brain damage and therefore worsening the epileptic network. I put a question mark here because this is very much depending on the type of seizures and on the type of epilepsy. Another option, let's say another process, if you want to generalize, could be the following. We have a brain insult, which can generate acute symptomatic seizure or a status epilepticus, SE, which generates brain damage. This condition then link this brain insult through the presence of this transient alteration to a brain damage. The acute, let's say, symptomatic elements then fade away, and then we can have the generation of epileptic networks, seizures, and back to seizure can generate further damage. So these are, I think, the two main general condition that I will be discussing. And I will start with some clinical work. I'm a neurologist as well, so we are developing here work on the human tissue, and we developed something, a study on the human focal cortical dysplasia. I'm afraid that this. Do you see this in my screen, in your screen? Should I remove it? No, I cannot. Okay. Sorry. I moved it out. Okay. So I have access to post-surgical tissue, and we thought that this tissue could be relevant and interesting to analyze the topic of do seizure damage the brain. Because this patient with focal cortical dysplasia, they have several seizures. This is usually in the early age, between let's say the first 10 years of life, sometimes later. In some cases, the dysplasia are not that much evident on the MRI, and so it is necessary to identify the epileptogenic zone with the steroid G recording. This is done at the Niguarda Institute, with which we are collaborating here in Milano. So they place electrode into the brain of patients, like in this case. Each letter is one electrode, is one rod actually, and on each rod, for example, J here, position here, you have several recording sites. Okay, so when you do steerology, you can record the seizure activity with this array of electrodes. Then when the region is identified from the electrical pattern, it can be removed and blocked and can be analyzed, okay? So we identify 16 patients that underwent steerage recording. They very frequent seizure, ranging from more than one per day to weekly seizures, and all seizures were recorded. So we have regions that we're recording from. Okay. The en bloc removal of the tissue includes not only the lesion itself, but also some tissue around the focal cortical dysplasia. And we can identify the entry point of the electrodes, so we can analyze exactly regions that have been the center of the focal cortical dysplasia and the close by region. And both these regions generated seizure activity. Okay? And this was, let's say, demonstrated by the steerage recordings. I'll give you an example here, another example. So this is a piece of brain that has been removed to cure the patient, and the patient is cured. And then we can cut this tissue. We can see that there is a clear lesion here, the focal cortical dysplasia, but also the removal, the tissue removal included a normal cortex, okay? Both this cortex and this cortex generated seizure activity, and the seizure activity was generated principally into the focal cortical dysplasia and then propagated to the perilesional tissue, okay? So this is the ideal model directly in human to analyze whether seizure generated here induce a damage there, where there is no lesion or in the perilesion. And that's what we did. So we saw that actually this is the lesion. This is the lesion. You can see a lot of gliosis here. In the perilesional cortex, there is no gliosis. Also, we analyzed the cell loss, so there is preservation of neurons up here, and also CD3 infiltration in the focal cortex dysplasia and in the surrounding tissue. And what we found is that in the normal tissue, this is the quantification, in the perilesion, in the non-lesional tissue, the cell number was not reduced compared to cryptogenic case that we use as control. And GFAP was not staining, that means gliosis was not present, and the number of inflammatory infiltrate was not present compared to the lesion. So this is a kind of demonstration that for focal cortical dysplasia, a lifelong of seizure activity does not generate a clear brain damage that we can identify with the immunostaining. Okay, so the seizure activity per se in this case does not induce remote structural injury in the surrounding tissue. So we use this as one of the examples of that actually against the idea that seizure generate damage. But the story is a little bit different when we talk about status epilepticus, and this is something we have been working on for a while. We know that the idea that started with the work of Raman Sankar, Paul Wostel, and Dave Naylor is that during status epilepticus, this was done in rats, there is a transfer of the staining for the GABA receptors from the inside, from the outside of the surface of the neurons into the body of the cell. And this internalization receptor was identified as one of the reasons why during status epilepticus there is difficulties in treatment, and these are not the status is continuing. So this is one of the first evidences, and we looked for something a little bit different. And looking at the literature, actually, there are a lot of evidence that if you induce status epilepticus with PTZ or by Q-colline and so on, then this does not induce chronic a chronic epileptic condition. While if you use pilocarpine intraperitoneal, you can induce status epilepticus associated with very extensive brain damage, which goes way beyond the region that usually is analyzed, which is the hippocampus. And in these statuses, these are convulsive status, so there is a generalized state of epilepsy. A nice model is in most of the temporal lobe epilepsy status epilepticum models, the seizure frequency has been described to be present in a chronic way, and then they remain stable with time. There are then other animal models where you have a very intense epileptic condition, like the mouse model of Dravet syndrome. In these animals, there is very little evidence for brain damage. So this tells us that actually, according to the way you induce an epileptiform activity or epileptiform status in the brain, this can generate different patterns. So we analyzed this a while ago with these few papers. A model which is interesting, which is the kainic acid model of interhippocampal injection of kainic acid. So we inject kainic acid in one hippocampus, and this generates seizure activity, which is here in the right hippocampus. We recorded also from the neocortex. When you have this seizure activity, this activity propagates to the contralateral side, where the kainic acid was not injected. So we can compare an area in which you have, okay, we can analyze a region where you have a damage induced by kainic acid and the seizures, and we can compare this with the contralateral side, where we only have seizure activity generated by this region. And the number of seizures which are generated during the status epilepticus induced by kainic acid injected to the kainic acid are equal on both sides of the brain, in the injected and in the contralateral side. And status means that you have continuous seizure one after the other for several hours. These seizures in this model are mostly focal, with a bilateral involvement of the brain. The majority of the seizures are like that in these 10 animals that we analyzed. And the duration of the status is several hours. If you apply diazepam before applying kainic acid into the hippocampus, the duration of the status is less, and also the number of seizures is less. This is important for something I will show you in a minute. Okay, then we took the brain of this animal at different times, 3 days after the status, or 1 month after the status. This is a sham animal, so it's being just implanted with electrode without any application of kainic acid. There is no alteration. Okay, sorry, there is no alteration in the brain. Okay. While in the kainic acid injected animal, the kainic acid was injected in the right hippocampus, there is cell loss in the hippocampus, but not in the contralateral, which received all the activity generated there, generated by kainic acid, and also produced independently some epileptiform activity. So if we quantify by this symptomatic analysis the amount of damage here, as you can see, is not different from the sham. So this is CA1 region, this region. This is CA3, so this area, and this is the dental gyrus, so this region here. As you can see, in the ipsilateral, in the region ipsilateral to kainic acid injection, when you, 3 days after the injection, you have a cell loss that is maintained also 1 month in the chronic condition. And if you apply diazepam, this cell loss is less than without diazepam application. If you look at the contralateral side, so the side that generates a seizure but without the canic acid injection, there is no changes between the sham and the other conditions in different regions. So CA1, CA3, and the Tajarus. In the contralateral area, there is no cell loss. What about gliosis? There's a lot of gliosis in the side that was injected with canic acid, as you can see here. So an increase in GFAP staining, both in the acute condition and in the chronic condition. And this was also present when you injected diazepam before the status was induced. While in the contralateral side here, there was a transient increase at 3 days of glial staining that after 1 month was completely reverted. And the same is in CA1, CA3, and then Tajarus. So there's a transient gliosis that then fades away in the following days. Okay. Then we look at the gene expression. So we took brains from the animals that were treated with canic acid. We isolated the hippocampus, and we did that with Erwin van Vliet in Holland, in the Netherlands. And then we analyzed the expression of RNA. Oops, sorry. And what we see is that most of the changes were observed in the ipsilateral, in contralateral. So in the ipsilateral, you have changes in the acute condition for the interleukin-1 beta, for example, and also in the contralateral side. This is not present anymore in the chronic condition, both in the region ipsi and contralateral to the injection. COX-2, which is another pro-inflammatory event, was not present contralaterally, no increase in gene expression. Also, these are other RNA. C-FOS was transiently increased in the contralateral, then went back to normal in the chronic condition. And aquaporin also was increased in the acute condition and went back into the chronic in the contralateral side, as well as in the ipsilateral side. And also KIR1, which is also the expression of this potassium is related to the potassium buffering competence of the tissue, was transiently increased. Okay, so to summarize this data, so 3 days after canic acid, in the ipsilateral brain injected ipsilateral to the canic acid injection, we have cell loss, we have gliosis, and we have also blood-brain leakage. I did not show you this data, but there was leakage of the albumin in the tissue. While in the contralateral side, there was no cell loss. So the side that generated seizure, but were not injected by the canic acid, there is some transient gliosis and no changes in the blood-brain barrier. After 1 month, 1 month after the canic acid injection, there's still cell loss, gliosis, and alteration of the blood-brain barrier, while all these events went back to normal in the contralateral side. So this suggests that indeed a region that generated a lot of seizures during the status epilepticus, but was not injected by canic acid, was not developing an obvious, let's say, structural brain damage. I mentioned before that we treated some of the animals with benzodiazepine, and this treatment actually reduced the amount of alteration in the tissue compared to the baseline condition. In the remote region, there was some alteration, while with the benzodiazepine treatment, that was not present. Okay, so these are our data. Then together with Erwin van Vliet, Christine Ekdal, and Andrea Rossetti, we look at the literature of the topic, and we wanted to analyze all the studies that have been done in the past on the brain pathology in the focal status epilepticus induced in animals. We did an extensive work on that, and we concluded the following. So if you induce a local temporal lobe epilepsy with hippocampal sclerosis by injecting either canic acid or pilocarpine into one hippocampus in the region ipsilateral to the injection, you have brain damage. This is shown by these, let's say, violet or whatever color it is, neurons. In the contralateral side, several studies show that indeed there is no contralateral damage. And in the region remote from the site of injection of canic acid, extralimbic region, there is no sign in those few papers that has been evaluated. There is very little, actually only a couple of papers, there is very little sign of extralimbic damage. This is happening when the type of status epilepticus induced by canic acid is a non-focal, a non-convulsive focal status epilepticus, so without convulsive seizures. So this is the pattern. A damage where you inject the canic acid, and very little, if any, damage in the contralateral side in extralimbic regions. While if the status is inducing convulsive seizures during the status epilepticus, then you can see also damage in the contralateral side, and this has been shown by these studies, but not by those other studies. While the studies of Cavallero, Benari, Moneta, and Retka, they showed also extralimbic alteration, only when convulsive seizures were generated during status epilepticus. So what can we conclude? Is that focal seizure activity during the status epilepticus can induce a transient expression of gene and proteins that are the expression of an enhanced glial function, which could be protected. This focal seizure during status epilepticus do not induce secondary damage in the remote region, but I did not show you this. The seizure themselves, they worsen the brain damage at the site of canic acid injection. And this was shown by the data with the pre-treatment with the benzodiazepine. So we see more damage in the case when we inject canic acid compared to the condition in which we inject canic acid in the presence of benzodiazepine that reduce the number of seizures. So the idea is that actually seizure activity can worsen the tissue damage induced by a local damage. So if you damage with canic acid, the seizure activity contribute to worsening that condition. Another conclusion of this revision of the literature is that convulsive seizure during the status may induce remote and secondary brain damage, even though this question should be addressed more in details. These are the people who have been involved in most of these studies, and I will stop here. And I think that even with the limited models that I showed you, so temporal lobe epilepsy induced by local injection of canic acid and the focal cortical dysplasia in the beginning of my talk, what we can see is that actually the different conditions can generate little changes in the same condition can generate different output. For example, again, if you have a temporal lobe sclerosis with, if you induce temporal lobe sclerosis with convulsive conditions, you can worsen brain damage, while the focal epileptiform activity only is not able to induce, let's say, prominent brain damage. With this, I will stop and I will give the floor to Marian, who will tell you a different story based on the data coming from the clinic. Please, Marian.
Thank you so much, Marco. This was really exciting data, and I think both stories are quite complementary. So we used mainly imaging data. We're looking mainly at adults with epilepsy, with focal epilepsy. So let's see what our part of the story is. Right, so these are my disclosures. And let's start with a clinical story. So when I talk to patients with the first diagnosis of epilepsy, I explain to them that epilepsy is sort of like a storm in the brain. And what we're actually measuring, what we're actually seeing are the lightning bolts. Those are the seizures. And similar to lightning bolts, seizures are also very unpredictable. So it's difficult to really say when and where they're going to hit. And that's part of the main issue of epilepsy, this unpredictability. But really what we're most interested in is rather the storm, not only the lightning bolts, but rather the storm. And this is sort of difficult to measure in epilepsy. So what we clearly see are the seizures, but what's behind that, what's causing seizures, that's really, really difficult to see in epilepsy. And now a frequent question of our patients is then, well, do these seizures actually harm my brain? Are they causing brain damage? And Mark already told you a lot about that, which is mostly reassuring. But nevertheless, I mean, this question has been discussed for the past almost 150 years. Sir William Gowers seems to have said seizures beget seizures, and he meant probably that if you have one seizure, then you may get another one and another one, and this may be a worsening condition. But is it really? And there's been a lot of research done in this direction and a lot of review articles. And as you can see, all of them have these question marks in their titles, and also the conclusions are a bit unclear. So it's a controversial topic. We won't give you a definitive answer today, but I think we'll try to look at it from two sort of different positions and two different views. Right. So I'll show you first a study that I quite like. It's very, very similar to Marco's study about the FCDs. And this study, it's actually just two patients that were seen at Queen Square in London. And these two patients had hippocampal and cortical malformations, but no hippocampal sclerosis, right? So they had a hippocampal malformation. They had seizures for more than 40 years. And after they died, they got an autopsy, and a neuropathologist looked at the hippocampi. So they had hippocampal seizures for 40 years, and there was no sign of hippocampal damage after 40 years of having convulsive seizures. So this fits nicely with the story that Marco was showing you. And I could almost stop here saying, okay, thank you, this is done. But it's a bit more complicated than that, and I'll show you why. So there are some conflicting findings coming from humans for sort of the whole story that seizures are just sort of an epiphenomenon. One comes from electrophysiological data. So again, this is a study from London where they looked at patients who were undergoing long-term EEG monitoring. And there was a certain portion of patients who had unilateral epileptiform discharges at their monitoring, and the other side was sort of okay. And some of these patients didn't decide to undergo surgery. So then a couple of years passed, and a couple of years later, they presented again to the video EEG telemetry unit. And 33%, so a third of these patients who had unilateral discharges in the past, during the second monitoring, they had bilateral discharges. And usually this didn't work the other way around. So if they had bilateral discharges at the beginning, they used to have bilateral discharges also at the second recording. But there seemed to be some sort of progression from unilateral electrophysiological activity to bilateral activity. Obviously, this has a lot of issues, this study, because it's retrospective and there may be some selection bias. But it's sort of an indication that there may be some progression of electrophysiological activity from unilateral to bilateral. Now, what about cognition? There's been a lot of discussion whether epilepsy is causing dementia, and this is clearly not our clinical experience. So we have young people with epilepsy, they are not going to develop dementia 20 or 30 years later. Obviously, epilepsy is a risk factor for dementia, but the question is, do they have accelerated cognitive decline? And this is a nice study that assessed around 50 cases with temporal lobe epilepsy and a matched group of healthy volunteers. And they underwent cognitive assessment at 2 time points, so at baseline and 4 years later. And this chart shows you the changes after 4 years. So all the bars are showing significant decline after 4 years. So during retest performance 4 years later. And in gray, you see people with epilepsy. So people with epilepsy much more likely than age-matched healthy controls to have significant cognitive decline after 4 years. So it shows you sort of that if you look really, really well, there seems to be some accelerated cognitive decline in people with epilepsy compared to healthy aging. This is not dementia, but slowly cognitive abilities seem to deteriorate a bit faster than in normal aging. So what about brain morphology? And many of you will know that temporal lobe epilepsy with hippocampal sclerosis is not strictly hippocampal disease, but it's a network disorder. And this has also been nicely shown using structural brain imaging and functional brain imaging. And this is one of the largest studies from the ENIGMA consortium of several hundred people with temporal lobe epilepsy with left or right hippocampal sclerosis. And you see that these red areas that are affected here in the cortex, so there is some sort of widespread cortical change, I would call it, and also in the thalamus here, that affects bilateral areas, even in unilateral temporal lobe epilepsy, similar in left hippocampal sclerosis and in right hippocampal sclerosis. And what's interesting in these studies is that the degree of these changes seem to correlate with the duration of epilepsy. So obviously, as the duration of epilepsy is longer, it's also associated with some aging process, but there is some indication that this may be sort of an ongoing process, right? And this is a study that we did a couple of years ago with a couple of Chinese colleagues. And here again, you see temporal lobe epilepsy versus healthy volunteers. You see these small cortical changes, cortical shrinkage, I would call it, a bit of a volume reduction of the hippocampus. But what's interesting here is when you look at siblings of people with temporal lobe epilepsy, you can already find some lower volumes of the hippocampus in siblings of people with temporal lobe epilepsy. So this sort of is an indication that familial or genetic factors may be contributing to hippocampal sclerosis or hippocampal volume reduction in these cases, even if these siblings never had epilepsy and never had seizures. But what's interesting here is that there are no cortical changes in siblings, at least not something that we could measure. And there's another study published around a year earlier than our study that shows a similar thing. So these cortical changes cannot be seen in siblings. So that's another indication that this may be something that's acquired during the course of the disease. So because all of these things that I've been showing so far, or most of the imaging things, were cross-sectional, that's an issue because everybody gets a bit older. The brain sort of continues shrinking during the aging process. And the best way to look at this is using longitudinal studies. So we did these longitudinal studies, and here you see 3 age groups of healthy volunteers, 18 to 35, 35 to 55, and those above 55 years old. And all these blue areas are sort of areas that have some brain shrinkage. And that's completely normal. That's part of the normal brain aging process. Now, if we look at people with focal epilepsy, and these are people from a tertiary epilepsy center, so mostly relatively severe cases with epilepsy, you see that all of them have these dark blue areas, particularly those that are older than 55. And these dark blue areas seem to have more accelerated brain aging or brain shrinkage compared to healthy controls. So I'm not speaking about neurodegeneration. I need to be very careful here because that's not necessarily what we're measuring with our imaging methods. It's rather a thinner cortex, whatever that means. And this process seemed to be ongoing, a bit quicker than the normal aging. So around twice as quick or even quicker than the normal aging in this tertiary epilepsy cohort. Now, the problem with this data is that it's collected in quite a selected population because this is a population seen in a tertiary clinic at Queen's Square in London in this case, and they tend to see quite severely affected cases that are treatment refractory. So we asked ourselves, well, what happens in the whole population with epilepsy. So this is something that's still in preparation. It's really, really old data, but we reanalyzed it. And this is population-based data, longitudinal data that has been collected at 2 time points in a prospective study. And the differences are not that huge anymore. So here in gray, you see sort of healthy brain aging, and in blue, you see sort of the aging in people with epilepsy. And you see that the aging process, or this brain shrinkage process, is slightly accelerated. We can also look at the numbers, and there clearly is significantly accelerated brain shrinkage in people with epilepsy compared to normal aging. And it's particularly visible in those who have focal epilepsy and in those who have brain lesions shown here. And it's much less in people who have generalized epilepsy. As Marco said, this probably very much depends on, first of all, what is the etiology of the epilepsy? Second, where the epilepsy is located. And now the question was, well, is this related to seizures? And that's quite interesting. So in the first study, we didn't really see a clear impact of seizures in this tertiary center study. In this one, we do see a difference. So we do see that those with ongoing seizures have a quicker sort of brain shrinkage compared to those who are seizure-free. But even people who are seizure-free here, even they seem to have a slightly quicker brain shrinkage compared to normal aging. So what does this tell us? It tells us that probably seizures are not the only thing contributing to all of this. And probably, well, we could say that maybe those with seizures simply have a more severe form of epilepsy. Right. This is shown in a bit of a different way. So again, here, these are the areas that had some accelerated brain shrinkage in those with ongoing seizures. And even those who were seizure-free had, at least in the hippocampus, a bit quicker sort of volume decline. And it also seemed to be sort of associated with seizure frequency, and particularly also with the history of tonic-clonic seizures. Now, the literature in humans on whether seizures contribute to these progressive changes that we see on structural MRI is very mixed. There are a couple of studies, including our studies, who say, well, it does not really, is not really clearly associated with seizure frequency. And we also see similar changes in those who are seizure-free, whereas there are other studies that saw an association with seizure frequency. So it's a bit of an open discussion. Now, my idea about this is that there are several factors that actually contribute to the development of the epileptic focus for example, now in TLE, which may be in the hippocampus here. So there clearly may be some genetic factors that are contributing to that, environmental factors or precipitating injuries that may lead to the development of epilepsy. And possibly also seizures may influence this process, but I don't believe that seizures are really the driver of all of this. And once the epileptic focus is established, then probably there is, it's not quite a static disease. There may be some ongoing changes, but these are very, very minor, and we need very sensitive imaging methods to detect them at all, you know. And probably it's not neurodegeneration in the classical sense, but it's rather whatever this thinning of the cortex means, you know. And we can discuss later during the discussion. And there are several factors that could contribute to this. It could be the network dysfunction. It could also be seizure activity. But as I said, we also see this in seizure-free cases. The process of aging, where brains of people with epilepsy can be more vulnerable, or the effects of head trauma, those who have repeated convulsive seizures. And of course, the effect of medication, because most of these cases are taking regular medication. The question is, well, is this actually preventable? Now, the way I see this is that really that seizures are only the tip of the iceberg, and that there's much more going on under the surface. And a lot of what we see probably on imaging is the effect of network dysfunction in epilepsy, and not necessarily an effect of seizures. And there's also cognitive impairment, social consequences. So we really need to see epilepsy in a more holistic view. And so this was one commentary on our article, and Dr. Shi here asks, well, a major part of what clinicians feel is successful treatment of patients with epilepsy, i.e. achieving seizure freedom, appears to have no bearing on a process that decreasing overall brain health. That is what we're seeing with brain imaging, and also possibly that what we see on repeated cognitive testing. And he was asking, well, would a surgical cure of epilepsy be more effective in stopping neural degeneration? So we looked at that. We used a very, very similar approach in this tertiary center cohort. And Up here, you see the pre-surgical imaging. Ooh, my mouse is really jumpy, sorry for that. So here you see these areas of accelerated shrinkage. And down here is after surgery. So this purple area is their area that was removed. And you still see some sort of a bit of shrinkage, but it's mostly Valerian degeneration, but most of it goes away. So if I show it in numbers, here in orange is sort of normal aging, and before surgery, this brain shrinkage process seems to be slightly accelerated. And after surgery, if surgery is successful particularly, it seems to go to levels that is comparable to normal aging. So that's sort of reassuring. It seems that if we manage to treat epilepsy efficiently, if we manage to disrupt the network disruption there, then we also stop sort of this ongoing process that we can measure there. Right. So let's get back to the first discussion. I was mostly talking about brief seizures so far. And similar to Marco, I will now talk a bit about status epilepticus. So let's show you a case. So this is a male in his early 40s. He was admitted to our A&E department because of a febrile illness that he had for 4 days. Then he felt slightly tired, had a change of character, was becoming aggressive. And then he had a convulsive seizure when he was in the ambulance and became unconscious following the seizure. And shortly time after that, he ended up on our intensive care unit. And we made the diagnosis of new onset refractory status epilepticus of unknown cause, so cryptogenic NORS. So cryptogenic NORS, or new onset refractory status epilepticus, it's one of the most terrible sort of forms of status epilepticus. It's usually very treatment refractory and affects people who have been quite healthy before that. And it's hypothesized to be associated with some inflammatory condition. Now, we treated him with all sorts of anti-epileptic drugs, sedatives, anti-inflammatory treatment, ketogenic diet, and it took us 2 months to really consistently stop status epilepticus. So we was on the intensive care unit for 2 months. Now, let's have a look what happened to his brain. And this is quite striking. So this is the first MRI that we did. You see these small ventricles here, and this is the 5th MRI we did during these 2 months. So we did 5 or more MRIs, and you already see that the ventricles are getting larger, that there's some sort of shrinkage, and we can quantify that. So here in red, you see the rate of decline of gray matter. So the first scan we put at 0. And after 5 scans, he lost around 13 to 15% of his gray matter. But this was a really severe case. He was at 2 months in the intensive care unit. And most of it happened during the first month. Right. Where was this located? It was literally everywhere. So all of the brain is blue. So all of the brain areas seem to have shrunk. And we also measured biomarkers of neurodegeneration in his blood. GFAP was mostly normal, but tau was almost 100 times higher at the beginning, and then quickly it went down. And neurofilament light, which is also a biomarker of axonal damage, was around 10 times higher compared to sort of a comparable cohort. So massively increased biomarkers of neurodegeneration during this time. And a biopsy was performed. So down here you see neuronal staining for neurons in a healthy individual, and up here is this case during biopsy. So you see clearly much fewer neurons in there, and he also had some reactive astrocytosis. So this is some new data I'm showing you, and this hasn't been published yet. We hope to publish it as a preprint in 1 or 2 months maybe. So we looked at it in more detail, and this is data from more than 2,000 MRIs and more than 550 individuals. And we mainly looked at people with new onset refractory status epilepticus, this really severe status epilepticus. It's a great cohort because these patients don't have big brain lesions, and it happens sort of to healthy people who didn't have any sort of significant diseases before that. And we did serial MRIs in these scans. We had 16 cases from our hospital and 17 cases from 6 other centers. And we had a bunch of control groups to compare it to. So let's jump straight to the findings. Now here in gray again, you see sort of the changes in healthy control groups. So each point is one scan, and one subject is connected by a line. But what you see here in blue and in orange are the NORS cases. You see how quickly the decline goes down. So they seem to have, in a very, very short time frame, a very rapid decline of gray matter volume. And if we quantify this, here in red is the overall Norse group. This is sort of the discovery and replication cohort, but the overall cohort is here in red. And because the differences were so huge, we had to put it on a logarithmic scale. So to put it into numbers, the rate of brain atrophy during Norse was 80 times higher than that during normal aging, and even 20 times higher than that during neurodegenerative conditions like Alzheimer's disease. Obviously, in a very, very short time frame, usually days to weeks or even months sometimes, but very, very rapid. So this was really striking. And I haven't seen another disease that shows this rate of brain shrinkage in such a short time frame. We again looked at, well, which areas are affected. It seems to be quite widespread. So very, very widespread, both hemispheres. We also had a look in a couple of cases. We had scanning after status epilepticus, and we're asking ourselves, well, does it grow back? And it doesn't seem to grow back. So here in red, you see red and orange are scans done during status epilepticus, it goes down, and in blue are scans done after status epilepticus, and it seems that it sort of stays there, right? So in all cases where we had some longitudinal scanning after status, it didn't seem to grow back. So this seems to be pretty irreversible. And it's quite striking. You can already see it with the naked eye. We also looked at blood and CSF biomarkers of neurodegeneration like neurofilament light, total tau, GFAP, and they are massively increased compared to comparison groups with epilepsy or autoimmune encephalitis. So red one is during status epilepticus, and blue one here is after status epilepticus. After status epilepticus, it goes back to sort of normal levels, but during status epilepticus, there's a massive increase here. So what would be my conclusion? And I think it fits slightly to what Marco was telling you so far. So what we see is that epilepsy seems to be associated with accelerated brain shrinkage. I'm very careful. I'm not saying neurodegeneration. I'm not saying neuronal damage, but brain shrinkage. And we can discuss later what this may be. And to be honest, brief seizures may play a role, but probably I don't believe these are the main factor contributing to this. And the way I conceptualize is I believe that there's some sort of a network dysfunction. And what we measure using MRI is an effect of this network dysfunction. There are even people who believe that this could actually be sort of a way of the brain to protect against seizures, sort of down regulation of certain areas, which then show this shrinkage on the MRI to disintegrate the epileptic network from other parts of the brain. Well, this is really open discussion. I'm a bit skeptical about that because this brain shrinkage seems to correlate with cognitive decline as well. So it's still unclear whether this is sort of a protective thing that we see on MRI imaging, or whether it's a pathological thing. Well, the data that we see in status epilepticus in humans is quite striking, I would say, particularly in these Norse cases, because those are really severe cases. And we see really high rates of brain atrophy, even higher than in neurodegenerative disease. Well, this is not only status epilepticus, this needs to be said. There are several causes that could contribute to that down here. So these patients, all of them have a lot of inflammation in their brain. That obviously contributes to that. But compared to autoimmune encephalitis, it's much, much quicker, the atrophy that we see there. There also is some effect of neurotoxicity during ICU because they get a lot of neurotoxic treatments and are intubated for a long time. But I personally believe that also this really long ongoing status epilepticus for several weeks or months may be a major cause of this atrophy that we see in these cases. That's all from my side. Thank you so much, and over to this discussion.
It was really amazing, Dr. Mayan and Dr. Marco. Thank you so much for the excellent talks and for sharing this wonderful insights regarding the impact of seizures on the brain. I believe these results are very important to encourage for early diagnosis and management of people with epilepsy. And I have a question. You said, for Dr. Marianne, you have said that in the pathology there was reactive astrocytosis, but the serum GFAP was normal, right? So what is the explanation for that? Because I believe that if there is reactive astrogliosis, maybe it is the reason for this network dysfunction, and maybe also contribute to the cognitive impairment and deterioration in this patient?
Yeah, so in this one case, we saw in blood we saw GFAP levels that were similar to an epilepsy comparison group. That's true. But if we look at it in the overall cohort of Norse cases that we analyzed, then we see a clear increase of GFAP during status epilepticus. So we see some whatever you call it, astrocytic damage or something like that, that can be measured using GFAP in serum overall. Yeah.
Okay, so it's different CSF GFAP from the serum GFAP. Maybe the CSF GFAP, did you assess or?
We didn't have CSF GFAP, but usually with sort of the new highly sensitive approaches, the CSF GFAP and serum GFAP are quite comparable, and they correlate quite well.
Thank you. I think now it's question time. Let's go through the Q&A box. Okay, and let's start by the first one. Thanks for the lecture. Is this knowledge applicable on the febrile status epilepticus? I think this question for maybe for both of you.
Yeah, maybe I'll start. I would say, well, what I was showing clearly is only new-onset refractory status epilepticus. It's not applicable to febrile status epilepticus. And I could also imagine if you have relatively short episodes of status epilepticus, which maybe take a couple of minutes or maybe an hour, the effects are much, much different to what we see in those terrible cases that are on the intensive care unit for a month or so. Probably there the effects are much smaller. And we're currently measuring that using a prospective study where we try to quantify this using repeated brain imaging. But it's a very ambitious and challenging study, and we hope to have some results in a couple of years. So that's sort of human data. What do you think, Marco?
Yeah, I think it's still an open question, but probably the answer is there. Because if we compare Norse type of status with, as you said, the status epilepticus that then is as severe at the very beginning, but is restored by appropriate treatment, there you can see if there is a difference, and this can actually give a partial answer to that. The problem with the status and with Norse is that at the end we do not know what it is due to, and this is the main problem. So maybe another way to answer to the question is to compare status condition where you have a very well-defined cause. For example, patient with an epilepsy, an ongoing epilepsy that stopped taking medication for some reason, they go into status, compare those with other patients where you have another very, very well-defined cause, and then see whether there is a difference based on the underlying cause.
Okay, so let's go to the next question. Is this also applies for now the next question? Why some patients with focal cortical dysplasia had learning and other cognitive abnormalities? This question also possible. Maybe Dr. Marco.
Yeah, when I talk about brain damage, I talk about structural alteration. So like gliosis, cell loss, and so on. But if epileptic form activity goes on in seizure, they go on for a while in a critical period of the life of the patient, that will generate a functional damage, which is not structural, but it is functional. And so that will alter the normal development of the brain if a status or a condition like focal cortical dysplasia is very florid in kids, and that then can generate something which is also the expression of the brain damage, but not of a structural alteration that we can measure with what we have as tool to measure the brain damage. So I'm not sure I answered the question, but
Thank you, Dr. Maya. Do you want to?
No, I think I completely agree. I don't have much to add. I think that was well summarized.
Okay, thank you so much. The next one, is this also applies for self-limiting focal seizures? I don't know. Do you do any research on self-limiting focal seizures?
not much. But one of the arguments against the idea that seizure begets seizure and so on was this self-limited or so-called benign forms of focal epilepsy that did not develop in anything. So but I think we are talking about really different diseases. And I mean, one of my strongest convictions in the last that I grew up with in the last 10 years is that when we talk about epilepsy, we talk of so many different diseases that is very difficult to compare. Also the pathophysiology, and also for this question, do seizure damage the brain, is difficult to put all in one basket. So probably we have to reanalyze the different topics that we are putting as a general question into the specific disease that express that form of epilepsy. Focal cortical dysplasia, autoimmune epilepsies, NORS, and so on. So the pathophysiology and the pathophysiology of these different diseases can generate different conditions where seizures may or may not be relevant.
Yes, I agree, and this also fits with the clinical experience that we have. I mean, we do not have the experience that people who have seizures keep on worsening, particularly if they're not treated, and that their clinical syndrome gets worse and worse over time, and that sort of treatment or suppression of seizures would actually make their epilepsy better. It's rather really just the suppression of seizures, and I don't think this has much effect on the clinical course of the epilepsy. I still believe that there's some sort of minor progression happening, probably not due to seizures. I still believe that there's something happening in the background. There is relatively good data showing that people who have a longer duration of epilepsy when undergoing epilepsy surgery have worse outcomes after epilepsy surgery, and there's some indication to that there is some process that is very, very, very slowly ongoing and may get worse over time. But the clinical experience clearly is not that. Those that have a first seizure and a second one, and that starts a cascade that worsens over time. And there's also evidence from things like the MESS study that delayed treatment after the first seizure is associated with similar long-term outcomes.
Okay, thank you so much. It's interesting. So the disease duration is very important, right? Like the worsening over the time and the disease duration, right? So it's maybe responsible for the shrinkage of the brain, because I think self-limited focal seizures, this duration maybe not so much. So, okay, thank you so much.
Absolutely. And well, we didn't assess like childhood seizures or children with epilepsy. And we analyzed only adults, and those with genetic causes or generalized epilepsy seem to have much less of this brain shrinkage. Now, in children, we need to be careful, because I'm quite convinced that, as Marcus said, in children, seizures may have a functional effect on brain development and on cognition. And this is a very vulnerable phase. So if children have seizures, and if they have many seizures, this epileptic activity might impact the cognitive development in these children, and then they just have a decline. Not necessarily as a process of neurodegeneration, rather than affecting the function. So in children, I would be much more careful than in adults.
Thank you so much. So the next one, what would be the contribution of the frequent spikes on neurodegeneration other than seizures? Maybe this related to the previous webinar. Okay, do you want to answer this question, Dr. Marianne?
So from our data, we didn't look at that, and I don't think we would find much of an effect probably, unless there's really like status epilepticus-like activity or something like that. Now, what I can say is there seems to be an association with neurodegeneration in the context of late onset epilepsy and dementia. So people with dementia who have epilepsy seem to have a more severe dementia syndrome and a quicker progression of dementia compared to those who do not have seizures. And also, if I have a patient who comes in who is 65, 70 years old and starts having mesotemporal seizures, very subtle seizures at this age with normal brain scanning, many of them complain about memory deficits, and these deficits may get worse over time and they may develop dementia. So that's an association here. And I believe in this case, epilepsy and seizures are not necessarily the cause of dementia, rather it's an indication that there's a neurodegenerative process going on, and a first sign of this neurodegenerative process is actually seizures. So it's a marker of dementia and a marker of a more severe neurodegenerative disease. So this is how I conceptualize it in older adults.
Thank you, Dr. Marianne. What about you, Dr. Marco? Do you want to add something?
Yeah, I think that Marianne is perfectly right. So if you have a pathological condition where you can identify some damage, like tau deposition, like an early dementia, their seizure activity can be worsening the damage, the underlying damage. There is no evidence for that. Probably there is some clinical evidence I'm not aware of. But the data that I showed on the completely different models show that indeed, if you have a damage due, for example, to hyaluronic acid, this damage can be worsened if you put on top of that seizure activity. So the same thing can be translated into the aging brain. So if you have an aging brain with some little structural alteration, dementia-like, let's say, seizure on top of that can speed up the process of degeneration, possibly. I don't know if there's any clear evidence on that, but
probably not clear evidence. There is some indication that synaptic activity increases, or sort of that the rate of amyloid accumulation is related to synaptic activity. And if you have seizures, you have more synaptic activity, so the rate of amyloid accumulation actually increases. And there's quite a big overlap between sort of the processes that cause hyperexcitability in Alzheimer's disease and in people with late onset epilepsy.
In this case, because the question was, do spikes damage? In that case, if you have an hyperexcitable activity, which is not only seizure, but spikes, that might contribute to the brain damage. Because as Maria said, if you have more synaptic activity, that could also during a simple spike, that could be bad thing for
probably in a vulnerable brain. Exactly. I think that's the key point. If the brain is vulnerable already, then seizures may contribute further.
Perfect, thank you so much. So the next one, any correlation between brain atrophy and the seizure prevalence? What do you mean by seizure prevalence?
I showed it briefly. So that this is really conflicting. Some studies said that sort of brain shrinkage, brain atrophy is correlated with seizure frequency. Others said, well, that's not correlated. So it's really difficult to say. Again, when you have more frequent seizures, you also have a more severe disease. So it's really difficult to distinguish, is it the seizures themselves, or is it like a bigger severity of epilepsy? And you can't distinguish these two things properly.
So it's not only the status epilepticus, which can cause brain damage, also the high frequency of seizures, even if it's just a short 1 minute or so. High frequency seizure can cause burnout or can cause shrinkage, right?
So my brief answer when patients ask me is that we do a lot of research on that it's still a bit unclear, and that I wouldn't be concerned that any sort of severe damage arises when they have many brief seizures, that there may be some very small damage happening. It's probably not a good thing to have many seizures, but I wouldn't be too concerned about their brain health or getting dementia or something like that. That's my sort of answer to patients for the whole topic, trying to summarize it.
Dr. Marco, do you want to add something?
No, I agree. I mean, not much to add to
Okay,
that.
thank you so much. So I think this is final question. Do you are you saying that it's contributed to the pathology and not to seizures itself, like the brain damage or the shrinkage of the brain? So it is related to the pathology of the seizure. So could you answer this,
I can
Marco?
think. Yes, this is one of the main issues. So when you see progressive damage, is it due to the underlying pathology which is developing with time? If you think about the channelopathy, for example, you have an alteration of the brain function that goes on and is possibly worsening the structure of that of the brain with the channelopathy with time, even though there is not a big evidence on that. But you expect that actually the brain is progressively worsening its performance, and this is difficult to let's say, distinguish from the seizure activity. All the original idea about the developmental encephalopathies was that actually developmental encephalopathies could be stopped if you stop the seizure, but that did not prove to be true. So even if you reduce seizures in developmental encephalopathy, you still have a developmental progression of the developmental damage. This actually tells us that indeed there is an underlying pathology that is worsening the damage in the brain, which is not strictly related to the seizure. Can be both, but it's difficult to distinguish.
Yes, thank you so much. Dr. Maya, do you want
So yeah, my short answer would be yes. I think that it's attributable mainly to pathology, and seizures play if they're brief, play a rather limited or smaller role in this regard. Yeah.
Yes, thank you so much. So before we end today's webinar, as the key idea of this webinar is to bridge the gap between basic science and the clinical. Dr. Mayan, do you have any questions for Dr. Marco regarding the pathophysiological mechanism of seizure causing the brain shrinkage, like synaptic organization or something? No. And also, Dr. Marco, do you want to ask any questions to Dr. Mayan?
I have a question to Marco, because now we're looking at this new onset refractory status epilepticus data, and I like to cite the classical Meldrum studies with those baboons where they had like status epilepticus for hours or so, and then he performed autopsy on them and he saw like clear signs of neurodegeneration. But what they then did is they used muscle relaxation and intubation, so all of the sort of breathing parameters were fine. And then there was almost no neurodegeneration left, just a tiny bit, but that's still it wasn't completely normal. So the conclusion was that most of the neurodegeneration that we see due to convulsive seizures is due to systemic issues. I completely agree with that, but they still saw a bit of neurodegeneration. So I was a bit surprised that you are saying, well, the contralateral cortex doesn't acquire much damage. Why do you think is that, or what do you think about the Meldrum studies in this regard?
I think that the body is doing a lot. So
yeah,
if you have a convulsive status epilepticus, the presence of frequent convulsion one after the other is generating more systemic a more systemic disease, which can then influence also the brain degeneration. I'm not sure I was that explicit on our study. We induce a focal status epilepticus. So if you do not record EEG from these animals, you don't see anything. They have some maybe they arrest behavior and so on, but they do not have a motor or compulsive seizure. So in that case, when you have a small activity generated bilaterally, on the other side, you don't have any evident brain damage as we can measure it. So this is another issue. Are we able to measure small changes in the degeneration, in alteration of the brain? That's why we did also the study on gene expression that actually did not help us that much. I mean, I think that immunohistochemistry is much more sensitive to show you something, but still is a limited tool. So
interesting. So if there's sort of relatively brief and relatively focal status epilepticus, that's sort of reassuring. I do agree with that. Yeah.
And I did not expect to ask something to Mariam, but
I was very clear, probably.
Yes. No, it was very clear. But I mean, knowing that he's a very expert of brain imaging and so on, of these aspects that he studied a lot. He mentioned the fact that actually sometimes you have with time a change in the expression of epilepsy, of seizure. So seizure in an older patient with longer story of seizure is more difficult to be removed, to get treated. Is there, if I remember well, you showed some evidence that actually with time, let's say, patient with long history of temporal epilepsy, they have a more intense damage of the temporal lobe, even though maybe there are difficulties to distinguish between the damage and the effect of time.
Exactly. I'm very careful not calling this damage, because we're really just showing some sort of shrinkage, whatever that means. Now, I think in this regard, interesting results are from the European Epilepsy Brain Bank that I mentioned shortly, and they have this large cohort of almost 10,000 patients who operated, and there is a correlation of duration of epilepsy. So when somebody has a longer duration of epilepsy and they get operated, they have worse outcomes. Now, obviously, there's a clear issue here that the more severe cases, or not the more severe, the more complicated cases will wait longer to get epilepsy surgery. So the surgeons will be less sort of enthusiastic about operating them, maybe. So that's the obvious caveat here, but I think that's clearly a bit concerning, and that's why we try to push our patients to go for epilepsy surgery as early as possible. And it's sort of supported by the data that we see before and after surgery on this brain shrinkage, that it seems to stop at least in the year after surgery. And that for me is another reason why performing surgery might be helpful. We do not know whether this is really brain damage, but at least this process that seems to be going on there, some sort of neural network dysfunction, seems to be successfully stopped and removed when surgery is efficient.
So our time for today is over, and I have to close the webinar here. Thank you again, our dear speakers, for this valuable discussion and for taking from your time to be here with us today. And thank you to the audience for joining us. And we would appreciate if you could complete the feedback survey, and see you all next session with the new modulation. And goodbye. Thank you so much. Bye-bye.
Thank you very much. Ciao, ciao. Bye.
Thank you.
Bye, everyone.
Bye, Dr. Maya.